Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Okay, let's unpack this. Today, we're diving into something really quite critical in healthcare, specifically within NHS general surgery. It's called never events. And you've shared some really insightful material that helps us get our heads around what these are, why they're so serious, and why, like the name says, they should just never happen.
Exactly. That name is very intentional.
Right. So our mission here in this deep dive is to, cut through the noise and really get to the heart of what never events mean, their impact, which is huge, on patients and the medical teams too, and how the NHS really works to prevent them. We want to give you a clear understanding, sort of the full picture without it feeling overwhelming. We'll touch on patient safety, but also systemic issues and the efforts to improve care. It's actually quite complex.
And I think it's vital right from the start to understand these aren't just mistakes. Never events have a formal definition. They are serious, but crucially, they are seen as wholly preventable patient safety incidents. They really shouldn't occur if the existing preventative measures are followed, especially in general surgery, which is obviously a critical area. They signal something deeper, potential failures in the system itself.
Okay, so wholly preventable is key there. So what actually makes something qualify? What tips an incident over into being called a never event? It sounds like the bar is pretty high.
It is, and it's very clearly defined by the NHS. There are essentially three main criteria. First, there has to be clear national guidance or safety standards already in place specifically designed to prevent that exact incident. We know how to stop it.
So it's not a surprise event?
No, exactly. It's a known risk with a known prevention strategy. Second, the consequences have to be severe. We're talking about death or permanent harm or the patient needing a much longer hospital stay than expected. Serious outcomes.
Right.
And third, the event itself has to be easily identifiable and measurable. Think of something really clear-cut like, wrong site surgery. No ambiguity there.
Okay, that makes sense. Very specific then.
It is. And building on that definition, there's the NHS Never Events framework. The latest version is from 2023. It's quite rigorous. If a never event happens, reporting it via DATIX, that's the NHS incident system, within 2 working days is mandatory.
2 days. That's fast.
Very. And that report automatically triggers a full serious incident investigation, an SI, a deep dive into what went wrong and why. And importantly, there are financial consequences too. Trusts can face reduced payments, so it hits their budget.
Ah, okay. So there's a real financial incentive to prevent these beyond the obvious patient safety aspect.
Absolutely.
Yeah.
The whole framework, the reporting, the investigation, the financial penalties, it's all designed to drive accountability, not just for individuals, but for the entire organization, the trust. It pushes for constant learning and improvement in safety systems, right up from the operating theater to the management level. It affects how hospitals manage their resources for prevention.
Okay, so now we've got the definition pinned down. Let's make it real.
Yeah.
What do these actually look like? What are some specific examples within general surgery? This is where it gets quite stark, I imagine.
It does, and unfortunately, certain types do appear more frequently than others in general surgery. We can break them down into a few key categories. First, probably the one people think of most is wrong side surgery.
Just sounds awful.
It is. Operating on the wrong side, like a hernia repair on the left instead of the right. Or a wrong orchidectomy, removing the wrong testicle. Or even a wrong limb amputation.
Oh.
Or wrong level spinal surgery. It happens maybe 50 to 100 times a year across the UK in total. The impact, it's devastating. Obvious psychological trauma for the patient. Loss of trust. And for the surgeons, the doctors involved, it often means GMC referrals, investigations by the General Medical Council, huge career implications.
And what causes something like that? It seems so basic.
Often the root causes are surprisingly basic. An incorrect consent form, maybe? Or crucially, failing to do the WHO timeout.
That pause before cutting.
Exactly. Where the whole team stops, confirms patient, procedure, site out loud. Sometimes it's rushed pre-op checks. Prevention relies heavily on universal use of that WHO surgical safety checklist. Meticulous site marking the surgeon, initialing the correct spot, ideally with the patient involved and awake, and double-checking scans, especially for things like hernia laterality. Simple checks, but they have to be done every single time.
Okay, what's next?
Next up is retained foreign objects, or RFOs, things left inside the patient after surgery.
Like sponges.
Swabs, yes, they're the most common. But it can also be instruments, clips, needles, or even guide wire, say, from putting in a central line. It happens roughly once in every 5,500 surgeries. And in about 90% of cases, the patient needs another operation just to get the object out. More risk, more trauma.
And the cause there? Counting errors?
Often, yes. Incorrect swab or instrument counts, or distractions in theater. Poor communication within the scrub team who are tracking everything. Prevention is all about strict, mandatory counting policies before, during, and before closing. Increasingly, technology helps too. Like radiofrequency tag swabs, RF Detect is one brand you can scan the patient to find a missing one. And having a no-fly zone, keeping loose instruments away from the immediate surgical area. Discipline in the theater.
Okay, that makes sense. Using tech as a backstop.
Precisely. Then we have wrong implant or prosthesis, using the incorrect medical device.
So like the wrong size knee joint.
Exactly. Or the wrong size mesh for a hernia repair. Or mismatched components for a hip replacement. Root causes often point to poor stock checks in the OR, or just not verifying the implant properly before it's open. Lack of barcode scanning, perhaps.
So the fix is better checks.
Yes. Barcode scanning for all implants is becoming standard, and a strict two-person check before anything is opened or implanted, a final verification step.
Right. 2 pairs of eyes.
Then, another important one, especially in emergency abdominal surgery laparotomies, is misplaced nasogastric NG tubes.
The feeding tubes.
Yes, or tubes for draining the stomach. If one accidentally goes into the lungs instead of the stomach and feed or medication is put down it can cause aspiration pneumonia, breathing stomach contents into the lungs. It has a mortality rate around 5%. Really serious.
And how does that happen?
Usually it's a failure to confirm the tube's position before using it, either with pH testing of the aspirate or getting an X-ray, or sometimes just inserting it blind without proper checks afterwards. Prevention relies on strictly following NICE guidelines. Check the pH. It should be acidic, 5.5 or less, before any use. If the pH is wrong or uncertain, get a chest X-ray to be sure. No shortcuts.
Okay. One more.
One more key category is unintended gas embolism.
Gas embolism. How?
This can occur during laparoscopic surgery, keyhole surgery. They use kale gas to inflate the abdomen. If a significant amount of that gas accidentally gets into a blood vessel and travels to the heart, it can block thread flow. It can be fatal.
Wow. How do surgeons prevent that?
Careful
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
monitoring of the patient's end-tidal KURLs, the KEO level they breathe out. A sudden drop is a major warning sign. And being careful not to use excessive gas pressure, generally keeping it below 15 mmHg. It's about technique and constant monitoring by the anesthetist and surgeon.
That range, it's quite something. From surgical sites to tubes to gas, it really highlights that these aren't always complex, high-tech failures, are they? Often it seems to come back to basic procedures, checks, communication, things we know how to do.
That's often the case. It's the consistent application of known safety behaviors that's the challenge. Human factors are huge.
Which brings us to the consequences. We know they're serious, but what does it actually mean when a never event happens? What are those ripple effects you mentioned?
Right, it's not just the immediate incident. The fallout is significant, and it affects everyone. For the patient, obviously, there's the potential for severe physical harm, needing more surgery, maybe permanent disability, definitely a longer recovery, but also the psychological trauma, that feeling of trust being broken. It can affect how they engage with healthcare forever.
I can only imagine, and for the doctors and nurses involved.
It's devastating for them, too, personally and professionally. There can be GMC investigations into their fitness to practice. That's incredibly stressful. There are often medical legal claims, which means NHS resolution paying out significant sums. And the reputational damage for the individuals involved and the whole team can be immense. These are dedicated professionals, and being involved in something like this takes a huge emotional toll.
Yeah, you don't go into medicine for that to happen.
Absolutely not. And then for the NHS trusts, the hospitals themselves, we mentioned the financial penalties, the reduced payments, that directly impacts their budget for other services. Plus, they can face CQC regulatory action. The Care Quality Commission can issue warnings, fines, even put the trust into special measures. That affects everyone working there and the public perception. So a never event really sends shockwaves through the entire system. It highlights a failure that needs fixing at multiple levels. Okay, so given those really severe consequences for everyone, How does the NHS actively try and stop these things? What are the strategies to actually build a safer system? It sounds like it needs to be more than just rules.
It absolutely does. It's about building multiple layers of defense. A multifaceted approach is essential. Firstly, there's a big focus on human factors training, understanding how humans work under pressure, how teams interact. This includes things like team briefs and debriefs before and after surgery, not just a chat, but structured communication. What's the plan? Any concerns? What did we learn? And using structured communication tools like SBR situation, background assessment recommendation, it helps get critical information across clearly, especially in handover situations, reducing misunderstanding.
Making communication more reliable.
Exactly. Secondly, using technology solutions as safety nets. Things like mandatory barcode scanning for implants and swabs. Takes human error out of verifying the right item. And RFID-tagged surgical items, swabs, or instruments with tiny trackable chips. Another layer to prevent retained objects. Technology supporting human vigilance.
Okay, so people and tech working together.
Precisely. Thirdly, and this is crucial, fostering a strong culture of safety. This means creating a blame-free reporting environment. Staff, including doctors and nurses, need to feel safe reporting errors and near misses without fear of punishment. That's how you learn.
So people aren't afraid to speak up.
Yes, and holding regular morbidity and mortality, M&M meetings, where never events, complications, even near misses are discussed openly by the clinical teams. It's about learning collectively from what happened, identifying trends, and changing practice locally, turning failures into lessons.
That sounds vital. Learning from mistakes.
It is. And finally, there's policy enforcement, making sure the rules are actually followed. This involves things like strict audits on WHO checklist compliance. Are teams really doing the timeout every time? And when a never event does happen, developing and implementing very specific never event action plans based on that root cause analysis.
Yeah.
Targeted fixes to stop it happening again. So, you see, it's a combination: human skills, technological aids, a supportive culture, and robust policies, all working together to strengthen the system against error. It's a constant effort for the doctors, nurses, and the whole NHS system.
Right. Let's make that even clearer. Sometimes a specific example really helps cement understanding. We have a case study here, that wrong site hernia repair you mentioned earlier. Let's unpack that a bit. What exactly happened there?
Okay, so this case involved a 65-year-old man scheduled for a right inguinal hernia repair. Standard enough procedure, but the error was that the left side was actually prepped for the surgery in the operating theater. The investigation found the main reason was an incorrect consent form. It listed the left side, not the right. Now, thankfully, the error was spotted during the procedure, specifically during the timeout check, just before the incision was planned. So the surgery was stopped before any cut was made on the wrong side.
Okay, so harm was avoided, but only just.
Exactly. The system worked at the last minute, but the potential for serious harm was absolutely there. The patient experienced significant distress, of course. The root cause analysis, the RCA, dug into why that incorrect consent form wasn't caught earlier. It found two main things. First, no site marking had been done. The surgeon hadn't marked the right side on the patient beforehand.
A basic step missed.
A basic but critical step. And second, the surgeon themselves hadn't personally verified the consent form details at the bedside with the patient before going into theater. They relied on earlier checks.
So the final check by the person doing the cutting didn't happen properly.
Correct. So the actions implemented by the trust afterwards were very direct. They brought in a mandatory site marking policy, absolutely no exceptions, and they strengthened the process for surgeon-led consent verification. The operating surgeon must personally confirm all details. Patient, procedure, side directly with the patient as a final check. It puts that responsibility squarely with the lead clinician at that final critical point. It reinforces how vital these routine checks are for the doctors and their teams.
It really shows how one or two missed steps in a known process can cascade, doesn't it? And how the fixes are often about reinforcing those known good practices.
Precisely. It often comes back to consistent adherence to well-established protocols.
Right, so we've really covered a lot of ground here on never events in NHS general surgery. It's clear they're incredibly serious, these incidents, but also, as the name implies, they really are viewed as preventable, avoidable, with the right systems and checks. And understanding how the NHS works to prevent them, the checklists, the human factors training, the tech, the safety culture, hopefully gives you, our listeners, a clearer insight into the safety measures that are there. Measures designed to protect patients and also to support the doctors, the nurses, the whole surgical team doing incredibly complex work, often under pressure.
Absolutely. And I think if there's one core takeaway from all the material we've looked at, It's this. A never event is not just an error. It's a system failure requiring systemic solutions. It's not about blaming individuals. It's about fixing the system. And perhaps that leaves us with a thought, maybe a question for you to consider. As we all strive for that ideal of perfect patient safety, what are the ongoing challenges? How do we maintain that constant vigilance, especially as surgery gets more complex and new technologies emerge? And how can everyone involved, the individual surgeons and nurses on the front line, and the wider NHS system, keep learning, keep adapting to ensure that patient care is not just effective, but fundamentally always safe?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.